This is a lecture on spinal cord injury. Spinal cord injury involves damage to the neural elements of the spinal cord. The damage may result from direct trauma to the cord, from penetrating wounds, or indirect injury resulting from vertebral fractures, fracture dislocations, or subluxations, like partial dislocations of the spine. Traumatic injury may be complicated by the loss of blood flow to the cord, with resulting infarction. Sudden complete transection of the spinal cord results in complete loss of motor, sensory, reflex, and autonomic functions below the level of injury. The immediate response to the spinal cord injury is referred to spinal cord shock. Signs and symptoms of that would be flaccid paralysis with loss of tendon reflexes below the level of injury, absence of somatic and visceral sensations below the level of injury, and loss of bowel and bladder function. Loss of systemic sympathetic vasomotor tone may cause vasodilation, increased venous capacity, and hypotension. Spinal cord injury is a disorder of young people. In terms of your mechanisms of injury, notice the flexion injury where you're moving forward, or there's the extension injury where you're moving backward. There's also the flexion rotation injury, so that's a twist. And then there's a compression injury. So if you have a fall, then that can compress the spinal cord. So most injuries result from some combination of compressive force or bending movements. The flexion injury, the head is struck from behind. With extension injuries, the hyperextension, that occurs with excessive forced bending backward. Then there's the flexion and extension injuries more commonly occurring to the cervical spine, C4 to C6. With the compression injury, that causes vertebral bones to shatter, squash, or even burst. That occurs when there's a spinal loading from a high velocity blow to the top of the head, or when landing forcibly on the feet or buttocks. This typically occurs at the cervical level, for example, with a diving injury, or in the thoracolumbar area, for example, falling from a distance and landing on the buttocks. It may occur when the vertebrae are weakened by conditions such as osteoporosis and cancer with bone metastasis. In terms of the primary injury, we're talking about the actual physical injury in itself. It occurs at the time of mechanical injury, and it is irreversible. It's characterized by small hemorrhages in the gray matter of the spinal cord, followed by edematous changes in the white matter that lead to necrosis of neural tissue. Following the primary injury, you have secondary injury. And so you have tissue destruction that occurs with this type of injury, resulting in progressive neural damage. With the spinal cord injury, there's vascular damage. Then there's neuronal injury that leads to loss of reflexes below the level of the injury, and the release of vasoactive agents and cellular enzymes. With vascular lesions, in other words, vessel trauma and hemorrhage, that leads to ischemia, increased vascular permeability, and edema. Blood flow to the spinal cord may be further compromised by spinal shock that results from a loss of vasomotor tone and neural reflexes below the level of injury. The release of vasoactive substances in question, we have norepinephrine, serotonin, dopamine, and histamine from the wound tissues. That causes vasospasms, and that impedes blood flow in the microcirculation. As a result, you have further necrosis of blood vessels and neurons. And the release of proteolytic and lipolytic enzymes from the injured cells causes delayed swelling demyelination, necrosis in the neuronal tissue in the spinal cord. In terms of signs and symptoms, the spinal cord segmental level, you have functional loss depending on the degree of the spinal cord damage, may not correspond to the vertebral level, particularly in the thoracolumbar and sacral level. But with spinal shock, you have loss of all reflex activity below the level of the injury, and the duration can be anywhere from 2 days to several months. It's associated with hypotension and bradycardia. Neurogenic shock is characterized by severe autonomic dysfunction, resulting in hypotension, relative bradycardia, peripheral vasodilation, and hypothermia. It does not usually occur with the spinal cord injury below level of T6, but shock is associated with the spinal cord injury involving the lower thoracic cord. Um, and that must be considered hemorrhagic until proven otherwise. With spinal shock, it's defined as a complete loss of all neurologic functioning, and that includes reflexes and rectal tone below a specific level that is associated with autonomic dysfunction. Neurogenic shock refers to the hemodynamic triad of hypotension, bradycardia, and peripheral vasodilation resulting from autonomic dysfunction and the interruption of sympathetic nervous system control in an acute spinal cord injury. More on signs and symptoms. Alterations in the body function depend um, or result from the spinal cord injury, depending on the level of injury and the amount of cord involvement. The degree of functional impairment of the spinal cord can be complete, so you may have total sensory or motor loss and autonomic disruption below the level of the lesion, reflecting irreversible spinal cord damage. The person can be tetraplegic, so that's four, sometimes referred to as quadriplegic, and that occurs with damage to cervical segments of the spinal cord. It results in impairment of functioning in the arms, trunk, legs, and pelvic organs. Damage above C6 results in paralysis of both arms and legs. If the injury occurs above C4, then loss of respiratory muscle functioning occurs, and that can lead to death. With the paraplegic, that occurs in the thoracic region and lumbar, 1 and 2 regions, or can occur in the sacral region. Arm functioning is spared, but functioning of the trunk, legs, pelvic organs may be impaired. So with incomplete and variable degrees of motor and or sensory loss below the level of lesion can reflect sparing of certain tracts. So types of spinal cord injury in terms of incomplete injuries. The central cord syndrome usually involves a cervical lesion with greater motor weakness in the upper extremities than in the lower extremities. The pattern of motor weakness shows greater distal involvement in the affected extremity than the proximal muscle weakness. Sensory loss is variable, and the patient is more likely to lose pain and or temperature sensation than proprioception and or vibration. Dysthesias may occur, especially those in the upper extremities. For example, sensation of burning in the hands or arms is very common. They can have, but the sacral sensory area is usually spared. With the anterior cord syndrome, that involves variable loss of motor function and pain and or temperature sensation with preservation of proprioception. Autonomic hyperreflexia or autonomic dysreflexia is a syndrome of massive imbalanced reflex sympathetic discharge occurring in patients with spinal cord injury above the splanchnic sympathetic outflow. So we're talking T5 through T6. This condition represents a medical emergency So recognizing and treating the earliest signs and symptoms efficiently can avoid dangerous sequelae of elevated blood pressure. In terms of the patho, there's a phenomenon that occurs after the phase of spinal shock in which the reflexes return. Individuals with injury above the major splanchnic outflow may develop autonomic dysreflexia. Below the injury, intact peripheral sensory nerves transmit impulses that ascend into the spinal thalamic and posterior columns to stimulate sympathetic neurons located in the intermediolateral gray matter of the spinal cord. The inhibitory outflow of the spinal cord injury from the cerebral vasomotor centers is decreased, but it is unable to pass the block of the spinal cord injury. This large sympathetic outflow causes release of various neurotransmitters like norepinephrine, dopamine, and you have piloerection, skin pallor, severe constriction in the arterial vasculature. The result is sudden elevation in blood pressure and vasodilation above the level of injury. So patients commonly have a headache caused by this vasodilation of pain-sensitive intracranial vessels. Vasomotor brainstem reflexes attempt to lower the blood pressure by increasing parasympathetic stimulation to the heart through the vagus nerve to cause compensatory bradycardia. This reflex action cannot compensate for severe vasoconstriction, and that's explained by Purcell's formula, where pressure in the tube is affected by the fourth power by change in the radius, so vasoconstriction, and only linearly by change in flow rate or bradycardia. Parasympathetic nerves prevail above the level of injury, which may be characterized by profuse sweating and vasodilation with skin flushing. So what did I just say? Okay, so let's just take a look at this. So you have a stimulus. It could be a distended bladder or a distended bowel or skin pain receptors. In other words, when your patients have spinal cord injuries and they're paralyzed, you have to be very mindful in making sure that the bladder is being drained so that they're urinating, whether they have a catheter or depending on the kind of catheter, you need to make sure that is draining properly. Because if the bladder gets distended, it can trigger this autonomic dysreflexia. Same thing. These persons, they can't move. They're on, based on maybe some of the medications that they're taking. Then they can get constipated. As that bowel distends, it can trigger this. You need to keep the pain level in areas that they can feel pain to a minimal level or none, because if they're in intense pain, it can trigger this. So whenever that happens, you have this reflexive arterial spasm, and that will send a strong impulse and cause a surge or an increase in the person's blood pressure. So you have this peripheral arterial hypertension occurring, and then the brain detects that and says, okay, we have a hypertensive crisis going on. So what happens is that we want to try to slow things down, so the baroreceptors are intact, and so what we do is deliver a message via the vagus nerve and also 9, and the brain will attempt to interrupt that hypertensive crisis. So this is why we get parasympathetics prevailing above the injury, above T6, because as you send these parasympathetic impulses, you can get down, but so far. Once you reach the injury, you can't go further than that. So the whole issue that started in the first place with the sympathetics is, constantly going on. So this is the reason that below the cord you have sympathetics that are prevailing. This concludes the discussion on spinal cord injury. If having questions, please contact me at halef@hawaii.edu.